WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today. WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today. WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today. WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today. WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly, interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today. WebSurge is proud to present an exciting new learning platform. Are you finding it tough to track down reliable information for hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user.
Good afternoon and welcome everybody. It is my great pleasure to welcome you at the episode 5 of Hernia Basecamp. I'm here with Andrew DeBow, and today we managed to persuade Professor Burwood to sit in the hot seat and talk to us about everything Botox related and abdominal wall repair related. So welcome and thank you very much for accepting the invitation.
Thank you very much. Happy to be here and thank you for the invitation, of course. As said before, I think we want to focus on the current practice of the use of Botulotoxin A in abdominal wall repairs. And so I hope to consider with you the general aspects of the use of this treatment. My disclosures are shown here, but not relevant for this talk today. And so when we talk about using Botox in abdominal wall repair, I think we talk about surgical strategy in the first place. We know that in the surgical strategy, it's important to consider, for example, prehabilitation of your patients, surgical techniques that we might have to use during the surgery, but also we have to focus on several pre-op tools that we might use in those type of mostly incisional hernias, like Botox and progressive pneumoperitoneum, and maybe which I will not discuss, the use of the fasciotats. Of course, determining your preoperative strategy includes several questions that you have to approach when you focus on your patient. What do you aim with your abdominal wall restoration? Do you want specifically to close your anterior fascia, or are you happy with some bridging and you just want to close your posterior sheet? Preoperatively, it's important to focus on several aspects, like is the reduction of the complete hernia content possible? Is there a loss of domain? And can you calculate the percentage of loss of domain, which might focus you on certain techniques specifically? The laxity of the muscular wall of the abdomen is of course important when we consider the use of Botox and the other techniques mentioned. And the last point that also is important to look at on the CT scan that you preoperatively perform in most of those patients is the fibrosis that you can see at the level of your transverse muscles. If we look at an example like this, very short, you have a very big hernia defect, loss of musculature of the rectus muscles, widening a gap of more than 20 centimeters, and you see quite long transverse muscles But the lower you get in the abdominal CT scan, you see that at the lower end, close to the pelvic bone, the musculature is more fibrosed and more scarred. So this might be a good indication to consider the use of botulinum toxin. First, I want to focus on the ins and outs of Botox treatment in hernia repair in general. It's, of course, as we mentioned, a tool, and I will focus a little bit on when we should think about it, how we can start our practice with it, and what are the points to pay attention to during the start. To introduce, of course, it's important to realize that hernia development, as shown already more than 15 years ago, is associated with the shortening of your lateral wall musculature and atrophy of your muscles. Your oblique muscles exhibit significant decreased extensibility at that level and an increased stiffness, as you saw also on the CT scan that I showed you before. Looking at those aspects, it was Tomás Ibarra-Hurtado from Mexico that already in 2009 introduced the infiltration of botulinum toxin type A before the restoration of the abdominal wall hernia that he treated. The working mechanism is not so unknown to most of us. I mean, we know the use of Botox for different other indications, and although in abdominal wall repair it's not that long used, we know that the Botox will introduce a flaccid paralysis in the muscle groups of the abdominal wall, with a gradual effect building up over the first days, with a maximum effect that has known to be 2 to 4 weeks. Of course, this might be important, and I will come back to that later, in the interval period that you include between the injection of your Botox and the definitive surgery. There are also some reports on pain modulation when using Botox, and also several papers are out there, but I will not focus on that aspect of the use of Botox in this talk. On the left side of the slide, you see the difference between two types of botulinum toxin, type E and type A on the right side. And it's effectively the period of time that the Botox needs to have its effect that is much longer in type E than in type A. That's one of the reasons. I'm not an expert in Botox per se, so I cannot give you other details on the differences per se, but one of the reasons to use Botox type A is effectively the period that the mechanism is reaching its maximum effect. Coming to which type of Botox we use, Botox type A is actually available in different traits. So we have the typical Botox, but we also have Dysport and Xeomin. And of course, it's important to realize that those differences exist, because if you look at the literature, the number of units that might be necessary to be used in your patients differ between the type of Botox that you apply. There are also some differences between the action modalities of Botox versus the other ones, different dilution concentrations, but of course, in general, they have the same mechanism. So it's probably depending on the availability of the product in your country or your center, which might make the decision for you. In general, it's injected with ultrasound guidance, and the number of injection sites and the timing, I will come back to that in a minute. What do we know so far in general about the Botox? It's generally well tolerated. We need to avoid intravascular injection because there is something that is called botulism-like syndrome, which might have severe side effects in case of really having a small dose injected in bigger vessels. So that should be avoided at any time. On the other hand, in the literature, although still off-label used, there are no specific adverse events or serious adverse events mentioned in the publications related to abdominal wall injection of botulinum toxin A. Minor side effects have been mentioned, like a bloating effect, a weaker strength in the muscles. Of course, that is logical because we want that to happen. And of course, in COPD patients, we should also be a little bit more careful maybe, because if you inject it towards the muscles of the diaphragm, it might have some effect on the respiratory status. On the other hand, if we look at the postoperative complication rates in most of the studies, we don't see any added effect on these complication rates after the use of botulinum toxin A. There are some non-responders, but most of the patients have a good response after the injection of botulotoxin and have the adequate effect after treatment. What is in general the mechanism that we expect from Botox to have on our abdominal wall? It has to do with the abdominal wall compliance, of course. It's the comparison between the change in pressure in the abdominal cavity compared to the volume that can be created. And you see in the graph that when you increase the intra-abdominal pressure on the left side and the y-axis compared to the abdominal volume, of course, those are strictly correlated. And after increasing the intra-abdominal pressure, you see at the upper side of the slide that the shape of the abdomen will also change from and reshaped towards stretching. If you increase the pressure in the abdominal cavity over time, the compliance will help the abdomen to get more volume inside. So that is actually something that we try to even more promote with using botulinum A. So just as a small overview from the general effects, we have a flaccid paralysis of our musculature of the abdominal wall after, let's say, 7 to 10 days. Maximum lengthening and maximum effect so far on CT scan has been observed after approximately 4 weeks, with an increase of the abdominal capacity, I will come back to that later, of around 20% in some series. No effect really observed or reported on trunk movement and breathing function per se, and the paralysis is of course temporarily and can last 6 to 8 months, after which the effect of Botox diminishes. So now, as an abdominal wall surgeon, of course, you might ask yourself, how should I do this in practice? Do I have to go look at someone that performs that procedure? Should I start it up myself? Should I collaborate with somebody else? I think, as I mentioned already, most of the studies need ultrasound for injection of the Botox. You can do it CT guided, but I think compared to the amount of radiation, that is not a preferred technique to do so. But of course, depending on your own experience with ultrasound, I think a collaboration with a radiologist or even an anesthesiologist that have often experiences in performing blocks for pain relief, they might be able to help you. At least you need a second person early in your experience to help you combining the ultrasound methods with injection of the Botox at the right level of the musculature. And last, but certainly not least, I think it's valuable, like in a lot of things in surgery, to have a standardized protocol when you start to really have a basis to have this technique developed. And over time, of course, you can modify here and there depending on your own experience. But I think there are several protocols out there, and I will show you some of them. First of all, I want to focus on the technique of injection. You see here several studies starting already in 2011 with Smoot, then Zielinski, Ibarra, Lopez, all mentioned different ways of injecting the Botox in the transverse muscular and oblique muscles. So without going into detail, I think it's not about one technique is better than the other. There are very little to no studies that really compare the injection effect depending on the site and the location. It's important, of course, to focus on the transverse musculature instead of the rectus muscle in most cases, and also to stay away from the hernia sac, because of course, if we talk about bigger hernia defects, the sac and the rectus muscle are coming much more laterally, and of course, it's to avoid to inject your Botox inside the peritoneal or hernia sac cavity. The injection is always together Botox with some saline. Depending on the product you use, as I mentioned before, the dilution of the product might differ a little bit, but you have to follow a standardized way of, let's say, mixing the product with saline, and also inject a number of cc in each muscle depending on the type of Botox that you use. In Ghent, we used from the beginning the protocol that was published here by the group of Zendayas and Zielinski, where they actually injected 300 units of Botox A in 150 cc of normal saline. So we have 3 syringes of 50 cc, each with 1 dose of Botox being 100 units. And we dilute it in 50 cc's of saline to inject approximately 8 cc in every muscle of the transverse muscles. So 3 times 8 cc per injection site if you use 3 sites at each flank. So it's a little bit of a calculation, but in general, it's always the same. So after you did a few, you know how to handle this and how to standardize your way of preparing this mixture. Is it necessary always to use 300 units? One point to consider there is the type of Botox A that you use. As you can see here in this slide, if you use another product, even for example, this port, you can go up to 500 units that has been described to have the maximum effect of your Botox in your patient. There are series that only use 100 units, reaching more or less the same effect. But of course, comparative studies in terms of dosage have not been performed so far as I know, at least. So to continue on how we do it in Ghent, as I said, we use the Zielinski method. We ask the patient in an ambulatory setting 4 to 6 weeks before surgery. I don't think you have to wait that long. On the other hand, if you go into surgery at a non-maximum effect of your Botox, maybe you might lose a little bit of its effect, and so we wait at least 4 to 6 weeks. It's ultrasound guided in collaboration with a radiologist in our center. Lateral decubitus position for the patient. We use 3 injection sites per side, per flank. Mid-axillary line, of course, depending on the size of the hernia gap between the costal margin and the iliac crest. It's important, I think, not to go too high up of the flank and reach the intercostal margins, because that might increase injection of Botox in intercostal muscles and influencing the respiratory status. 300 units of Botox diluted in 150, as I mentioned before, and approximately 8 cc per muscle at each injection site. We use an 18 gauge spinal needle. We have a probe next to the, or a guide bracket next to the ultrasound probe that we use to effectively reach the deepest muscle first. So the transversal we try to visualize first, and then return the needle back outside to reach the internal oblique and the external oblique muscle. Just to check on what we achieved, we do a CT scan control 7 to 14 days after, after the injection and before the surgery, as I said, most of the time 4 to 6 weeks after. Here you see this in practice. We have this little bracket next to the probe to really focus on the area of injection after visualizing the different muscle layers. At the left side, you see this picture where it's very clear. It cannot be more easy for a surgeon to inject Botox in these 3 muscle layers. But on the right side, you see a different patient, large hernia, same diameter, but a completely destroyed interlayer muscle situation. So very difficult to realize if you really infiltrate the Botox in the transverse muscle. Maybe the external oblique is more clear, but often the difference between internal oblique and transverse is rather vague. Is it therefore important to infiltrate all 3 muscles so much? I'm not sure. There have been studies and opinions more that might say that it's good enough if you infiltrate the external and the oblique and the internal oblique, and that you stay away from the transverse, also because it might help in your respiratory function. Can we evaluate how well we infiltrate the Botox? Of course, we can see the dissemination of the Botox in the muscle that you infiltrate. You see the fluid coming in, you see the needle trajectory to be entered into the muscle site, and so we can evaluate what is happening during the ultrasound evaluation. So that's an important point, that you know that you don't over-treat one muscle or that you reach all the 3 muscles separately. If you evaluate the situation, for example, 2-3 weeks after the infiltration with Botox, you see this type of CT scans. On the left side, the situation pre-treatment with quite fibrosed transverse muscles, and then elongation over the weeks after the treatment with Botox to actually diminish or reduce the hernia gap significantly to help you to close the anterior abdominal wall during surgery. Coming back to the ideal waiting period, I think it's clear that there is not one fixed best waiting period in general. You see here a study from 2017 by the Danish group that showed actually quite some differences in the waiting time, not really differences in effect. As I said, I think it's logical to at least try to reach the maximum effect of your Botox depending on the type of trait that you use. But better probably a little bit too long waiting than too short to have not your maximum effect. At least that's my opinion. Then another important point to focus on a little bit is actually the indication to start using Botox for. Is it a solution for every hernia, every large hernia, or are there specific indications that might be more in favor than others? As I mentioned in the beginning, we have different tools, both surgically and non-surgically. And of course, we have to figure out, and I think that's one of the most important, difficult issues for large hernia repair so far, is how we can use those techniques for the right patient and also in what combination, which are invasive, more demanding for the patient, and which can help us as good as the more invasive techniques might do. Of course, there is a lot of literature out there now that focuses, and almost for every indication in abdominal wall restoration, there is a paper that says we can do it, it's feasible, it's safe, and even for big defects in laparoscopic repair, there have been some papers out there, specifically from Australia, that say that the preoperative Botox treatment helps you to close the defect during this minimally invasive surgery. But as I mentioned before, and I hope that you have still that in mind, we should consider the thickness of the muscles. If the muscle, for example, over the whole area of your abdominal wall CT scan is very thin and elongated already, personally, I have no proof about that, but in clinical use, I think what would be the extra benefit of Botox in those patients? If they are thickened and they are fibrotic, of course, the relevance of using Botox pre-treatment is much more obvious. What to say about moderate hernia gaps? If we have defects of, let's say, 6, 8, or maybe even up to 10 centimeters, there it becomes probably already a little bit more clear, but let's say 6 to 8 centimeters. Is it useful to use Botox in those patients? It comes at a certain cost. In some countries, this might be an issue, in others, it won't. But we have to consider it because, of course, it's a pre-treatment with some extra pain for the patient during the infiltration. If we don't need it, probably we should not do it. Or do we use it only specifically for giant hernia defects, really large, over 20 centimeters, where we are pretty sure that it helps us to get the gap smaller? There are very recent 2023 systematic reviews that look at the effects of Botox, and they all agree on the positive effects of this pre-treatment in the advancement of the musculature to the midline, to decrease the transverse diameter of the hernia defect, very small to no complications reported. Of course, we know in surgery it's always a matter of do you want to report your terrible cases? But in general, the complications reported on Botox treatments are really, really low and very minor. And of course, the studies show an increased facial closure rate with Botox compared to no Botox pre-treatment. I will come back to that very shortly in a minute. So here you see a study of this year published in Surgery by one of the Americans group of Todd Hannaford that actually did a propensity scored match study comparing the patients that had component separation technique versus a little bit less patients in that group of the Botox treatment alone. And actually, after matching those patients, they showed that the preoperative Botox treatment versus the component separation technique achieved similar rates of facial closure rate. In the end, that is the primary outcome of our abdominal wall reconstruction goal. Without, of course, in the Botox-treated patients, the postoperative morbidity that we might see after component separation technique. So an important paper that actually progressed on a paper that I show you now, done in Valencia by the Spanish group of Buenoledo, that actually compared 40 patients with Botox treatment preoperatively, and then looked at those patients whether they needed still component separation during surgery. And they compared those patients with more or less similar hernia defects where they performed component separation in all patients. This study included 40 patients in both groups, and without going into details, they showed that actually the same as shown in the previous slide, that the patients that received pre-treatment by Botox, only in 10% approximately needed component separation additionally to the pre-treatment with Botox. Of course, the other group had an anterior component separation technique as a standard, and of course were closed almost in the same way with the same facial closure rate as the pre-treated Botox group. So in general, I think it's clear from at least already those two studies that Botox might move us towards a situation where we limit the use of component separation technique in, let's say, the moderate to large hernia gaps. This is a forest plot from the group of Maria Burmeister that was published in Hernia in 2021, where they looked actually at the 3 studies that really compared no Botox pretreatment versus Botox pretreatment and looked at the facial closure rate between those patient groups. And as you can see, all studies showed more or less the same outcome with the benefit of pretreatment with BTA achieving better facial closure rate comparing to no pretreatment. So what can Botox do? I hope I showed you that it increases the effect of medial mobilization of the fascia, that it preserves your anatomy, and therefore, as I try to show, component separation techniques might not be necessary in those patients to close the hernia gap. But one of the questions that remains is, does it really create extra intraperitoneal volume or space? And does it help in loss of domain patients, or should we combine it with other techniques? There were some studies, also recent, also a little bit older, that looked at the volumetry after the pretreatment with Botox. And actually this study from Brazil showed that there was indeed a reduction in the ratio between the hernia volume and the abdominal cavity volume from 30 to 23%. So that is important to show that your volume, intra-abdominal volume, will increase after the use of Botox. But of course, the question remains, where is the cutoff? When is this 20% that we always talk about, 20, 25% as a real loss of domain? Can that still be solved by only Botox use? And of course, if you look at the percentages shown here, you might question that, I think. Could we combine Botox then with other techniques, more aggressive techniques like the progressive pneumoperitoneum? The results and the jury maybe is still out there, because there is this study from France that shows actually no real benefit of adding preoperative progressive pneumoperitoneum to the adjunct of Botox in patients with a significant loss of domain. What they saw, a little bit surprisingly, is that they had less postoperative complications in the patients that had the combination of the two techniques, but no higher facial closure rate using one technique, being Botox only, or adding the preoperative progressive pneumoperitoneum. On the other hand, our group in Ghent showed that in using this treatment algorithm, without going into detail, that the addition of Botox and pneumoperitoneum reaches actually a closure rate of close to 90% in defects over 18 centimeters in width. Of course, it depends on the patient population. It's most often a very heterogeneous population, so maybe not always comparable between studies, but I think it's not yet really known whether the combination will do much more versus Botox only, although personally I think that if you really have a significant loss of domain, 30, 40, 50 or more %, I think pneumoperitoneum will certainly give you more volume gain than Botox only. But that's a personal opinion and not really shown in the literature as such. So coming to the end of my talk, I think, of course, we need to discuss maybe the middle of the slide here, whether the place of Botox should be moving more to the left side and replace the component separation technique that we have now earlier in our surgical toolbox, being hernias between 10 and 14 centimeters that we now treat with TAR. Maybe they could be treated with using Botox only, not needing a posterior component separation technique. And of course, we need to evaluate other tools like the fasciotens in the very large hernias, but that is certainly outside the scope of this talk. So in conclusions, ladies and gentlemen, I think Botox infiltration is certainly an important asset to the armamentarium of the hernia surgeon nowadays. I think the importance of using Botox might increase, but we have to be careful because it's still off-label use and we have no real clinical evidence that the use cannot harm our patient. The reports on that are very, very little to non-existing, but of course, off-label, we should always be careful. And Botox alone might not be sufficient for treating really the largest gaps with significant loss of domain issues, and we might need other techniques to join the Botox treatment. Thank you very much for your attention.
Thank you, Frederick. That's an absolute masterclass in Botox. Obviously, it is off-label, but I think thousands of patients have had it injected around the world, so there's increasing evidence around its safety. Are there any contraindications? Are there any people who you shouldn't Botox?
Very good point. Indeed, I think the clinical evidence is pretty large out there nowadays, but I think for contraindications, we mainly have to focus on everything that's related to respiratory problems. So for example, you have the muscle diseases like myasthenia gravis. I don't know whether I pronounce it well. And of course, like I said, there are some people that also consider COPD patients as a possible or relative contraindication to use it. Personally, in Ghent, we used it also in COPD patients in case, of course, they have not COPD grade 4 because they are not even valuable for surgery. But in the early stages of COPD, we don't see that as a contraindication. Also, because I think if you stick to the infiltration points at the flanks of your abdominal wall, the chances that you really reach the musculature that is needed for respiratory function are very, very small, and it's not really a problem as such. But of course, in myasthenia gravis patients, you should be careful. Although I didn't see any papers related to that specifically, but I can imagine working on the same mechanism with your receptors of the muscle that you should be careful in that case.
I'm not an expert in myasthenia gravis either, but I presume there'd be higher risks in myasthenia gravis if you get inadvertent intravascular injection.
Yeah.
And
sure
then you would have a systemic effect. Yeah. One of the interesting things here is the philosophy about Botox versus component separation. Because for many people who are proponents of posterior component separation, the reason for posterior component separation or the benefit of posterior component separation is partly medialization, but it essentially allows a very large piece of mesh to be inserted. And some people will argue that the mesh defect area ratio, when you're confined to the retrorectus area for a midline, doesn't give you a wide enough mesh. Whereas Botox will allow you to get medialization also, it then negates the ability to have a wider or more lateralized mesh. How do you sort of rationalize that philosophy?
Yeah, I think it's like you say, it's completely true. I mean, a lot of things that we consider, I think, in these large abdominal wall defects is about what do you believe. In the way, what I mean by that is that, of course, if we have recurrences, normally it happens in the midline and not outside, and not even if you perform component separation well, and not even at the semilunar line. So in general, I agree fully. If you have defects more laterally, that TAR is probably more helpful to have a good reconstruction of your abdominal wall. because you can reinforce also the lateral defect that is there. If we talk about a midline incisional hernia, and you can use Botox without using component separation and reinforce with a normal sized retrorectus mesh, that should do the job, in my mind. But of course, you could differ, different patient characteristics, different hernia characteristics, and as long as you as a surgeon decide I need larger overlap, TAR of course is a very good technique to achieve that.
I'm hogging the conversation, Barbara, and I'm conscious of that. Could I ask one more question before I let you say something? It's unusual that a gentleman gets to speak first. But another philosophical concept, there are concerns about injections with COPD, particularly if it takes out the diaphragm. The corollary to that is that the larger the hernia, the larger the loss of domain. When you've done the repair, the higher potential intra-abdominal pressure you'll be left with, almost to the point where you may have a true abdominal compartment syndrome. Is there any evidence or any reports that those patients who've had Botox find it easier to breathe post-surgery because they have paralysis of their lateral abdominal muscles, and therefore it's easier for them to actually breathe? So it may be that COPD is an absolute indication for Botox, even in smaller hernias.
Certainly a good point. I'm not sure that there are, not to my knowledge at least, really studies that compared those situations as such. What is of course the case is that it's logical that if you have more space and less pressure on your diaphragm to breathe, that after surgery and pre-treatment with Botox, this might facilitate respiration afterwards. But I'm not sure there have been any studies really comparing one versus the other to answer that question. As I have to say, a lot of things that we still present are not like mathematically yes or no, and is based on experience of others, of yourself, finding out the best way to treat your patients in your setting.
Barbara, I've hugged the conversation. I'll let you get in.
Thank you very much. One of the downsides of your talks is every time you come up with a question, you immediately answer it. So it's very hard to come up with new ones. But I have written down a few. You mentioned about the combination of Botox and pneumoperitoneum. And just thinking logically, isn't that a little bit of an overkill? Like, what else can we elongate in the abdominal wall? If the Botox already did the job, what else can we stretch?
Yes, very good point. I think, first of all, it's important to realize that, at least in my opinion, and certainly some might disagree, but I think progressive pneumoperitoneum is something that you should limit to only the cases that you're pretty sure you need it. In the way that it's much more aggressive, the complications that have been reported also in a systematic review are much more important than seen with Botox only. So I think progressive pneumoperitoneum is certainly not something that you want to introduce in moderate gaps with a little bit of loss of domain. I think that is much too aggressive and overkill, like you stated. On the other hand, what personally I like a lot about the pneumoperitoneum is that you see your patient tolerating increased intra-abdominal pressure, that you see the contents getting back into the abdominal cavity, knowing that you're moving in the right direction, being able to treat these patients. If we perform progressive pneumoperitoneum on a certain patient with a big defect, we did Botox, we start using the PPP, and we see not a good evolution in the reduction of the content inside the cavity, we have once in a while, not often, but once in a while, we have a patient, we say, we will not get there because they don't tolerate already the increased intra-abdominal pressure, respiratory mostly. They don't tolerate it, so they will not tolerate surgery. They will be at a high risk of developing an abdominal compartment syndrome. So in those specific, very small part of the patients, I think it's very helpful, but certainly not a technique that we should introduce much earlier in the algorithm, let's say.
And can you comment a little bit on you mentioned there's 10% of non-responders, maybe those would also be the right group to.
Can you
Yes,
predict non-responders?
I questioned myself that as well, but I don't have the answer. What we see, but the problem for us, because we thought about it quite often, if we have a patient that we don't see so much effect as we expect after treatment with Botox, we say, okay, that is us not performing the procedure well. Because there is some reaction, of course, the measurement might differ a little bit, so you are not sure whether it's no response or maybe partial response. And so I'm not sure, and also not an expert, to know if this is possible or is it necessary to test this before you use it, or that we can just say, okay, we have less effect, but we did no harm. So we need to build up a different strategy to help this patient because Botox didn't do what we expected it to do. But it's around 10% in the literature that is really a primary non-responder, but we did not come across to patients that did not respond at all and we had no benefit at all. We just saw partial or less than expected results.
And could it be that maybe when you mentioned the fibrotic muscles and that the chemical only didn't get to the right spot?
That is how we explain it indeed. Like, okay, we did not see in this patient very good the different layers, so probably we infiltrated one muscle and not the other. And because, as I try to show, that is sometimes really difficult to see where is your muscle layer ending and starting the other one. Mostly you have that with eliminating the transverse muscle only, and you can most of the time see the external internal, so that should be okay because transverse is probably less important to have the relaxation. On the other hand, we are not always sure that we have two muscles correctly. So sometimes that can happen, and therefore we explain it like that if we have less effect. But maybe it's partially non-responder or non-responder at all.
So has anybody actually looked in the past at which muscles have the biggest effect on pulling the muscles laterally? Like which one is the most important? Which one you should go for? You mentioned that the transverse abdominis is maybe less important in this. So,
of course, the transverse muscle is important for function and the body contour, the constitution of the system of the muscles. But the elongation, like we see in the component separation techniques, actually comes mainly from relaxation from the external and internal oblique. That has been shown in percentages.
And if you inject it into the transverse as well, have you observed back pain? For example? No.
You see a lot of differences how patients experience the injection of Botox. You have patients that really say, okay, it hurt a lot when you inject it, but afterwards I did not feel any change, but they have quite a nice response on CT scan. Some people say, yeah, I felt it really. I couldn't cough so well. I felt less strength. I had the impression that I was like this instead of standing up. And then you see the same result on CT. So it differs really how patients experience it, but real indications that there were trouble, no, we did not see.
Scheduling of patients after Botox. I work in the UK where we're famous for cancelling patients and then they wait months thereafter. And I thought when we introduced Botox, this would be great. I could say to the team, they've got Botox, they have to have an operation, but they still say, no, this patient is cancelled. Do you have any experience of how long you can wait before you would have to re-Botox to get the effect prior to abdominal wall repair?
It's really an anecdotal experience. We had one patient that had trouble where we combined Botox and pneumoperitoneum. During the pneumoperitoneum, there were some complications of bleeding inside the abdominal cavity. So we had to stop, we had to let the patient recover and so on and so on. And we waited 4 months, did a CT scan, and still saw the same elongation as we did after 2 weeks of Botox. So I think you have certainly some time, but I don't know. It's, as I mentioned, it's the working mechanism is there for 6 to 8 months, they say. We don't have experience with really that long of waiting periods. We never re-injected patients with Botox. So personally, I cannot say, and I did not find that in the literature either. So I'm not sure we are there yet. There are 1 or 2 papers that focus on the long-term outcome after pre-treatment with Botox and show that actually when you do an EMG for evaluating the muscle function, that they returned indeed to normal after 8 to 10 months measuring then. So there is something to it, but I don't have the personal experience on that.
You made it quite clear, and I would agree with you, that Botox is not for everyone, in a sense that for every abdominal wall repair. And if we look at the recently published EHS incisional hernia guidelines, I think, which the three of us were part of, it does mention key question 3, I think, was about fascial closure. And there was a desire that fascial closure should be encouraged as far as possible. And then it went on to identify groups at risk of fascial closure. Now, the problem with numbers, as you've stated too, and I don't like algorithms either, it's not surgery by numbers. But if you look at the numbers, once your width is greater than 8 centimeters, once your hernia defect is greater than, I think, 164 square centimeters, the rectus hernia width, the Carbonell rule, help me here, was it 1.34 was, and then the component separation index less than 0.0104. You need to look up the paper in the BGS to confirm that, but they're just numbers. But like all these things, you can get very wide defects which close easily, and you can get relatively narrow defects that don't close well. Clinically, CT-wise, how do you decide, partly by number, maybe by feel, but what's going through your head as you see the patient, see their CT, and you decide Botox yes or Botox no?
Yes, I think patient constitution is very important in that aspect for me. I think in obese patients, I would also lower the threshold for using Botox in even somewhat smaller defects like 8 centimeters, because I think if you start separating the layers of the fascia in posterior sheet, anterior sheet, it gets in those more obese patients more difficult to do the layered closure. And so, of course, you have then to lower your threshold to start Botox. That's one point. Of course, the gap is a second point. The laxity you can evaluate. Of course, you might say, yeah, that needs experience, like everything. But what you find out, okay, here I have a nice reduction of my hernia on the clinical examination. The skin as well as the inside comes together quite nicely. Don't worry, this I will be able to manage. On the other hand, I think as for us also, and also in the literature, the side effects are so minimal. I think personally, I'm in favor of taking the safe side. And if you think this might be a little bit more difficult than I expect because of previous surgeries, because of other reasons why you think the abdominal wall might be scarred in the flanks, I would go for Botox and take the safe side. Maybe overtreat 1 or 2, but better that than be there, need to do an extensive component separation while you could easily have closed it using Botox. That's at least my opinion.
So lowering your threshold for obese patients.
Yes.
Weight loss, if you can get patients to lose weight, that may take away the need for Botox. Again, your sort of laxity test, everything seems to come together quite nicely.
I think it's part of the prehabilitation that is more and more in focus, more and more important. So I certainly think that is an aspect that you should look at first to
The key is it's not just numbers, it's patient assessment,
absolutely.
And it's assessing the response as to what's going on. Barbara, do you have any other questions?
Yeah. You say the effect of Botox lasts for several months. So are you aware of any study, or have you observed yourself any effect on the postoperative pain when patients who did receive Botox?
There are some studies looking at pain, and they come with the, let's say, weak conclusion that it helps. The problem there, and certainly in our center, we are a little bit maybe old-fashioned. We work still a lot with pain killing through intravenous or even epidural in the very large defects. And then I cannot say in our comparison between Botox and no Botox that there is a difference in the amount of analgesic consumption that patients have. But we did not study it ourselves specifically by taking a protocol wise and say, okay, if we don't use epidural, then we see a difference and so on. In the literature, the weak studies that there are say, yeah, it might work like we see in the mechanism. It might work in favor of a little bit less pain postoperatively, but I think the data is very, very weak.
It's one thing that made me wonder. Um, you injected into 3 points, and
Yes.
all these points are actually relatively low. Like the highest one was somewhere the 10th rib layer, roughly. And you injected somewhere in the muscle belly,
Mhm.
roughly in the middle of it, or you know. So do you think, compared to the other protocols that inject at more spots, is there any difference as to how many of these neuromuscular connections you actually block with the different protocols? Is there some logic behind
Well,
that?
I think the logic or the theoretical advantage might be there. I mean, the more spots you treat, you might think that you have a more effective treatment of relaxing the muscle. On the other hand, don't forget that we inject into a sheath of the muscle. And so what happens, even you see it when you inject, is that it really spreads over the muscle at that level. And of course, if you use 3 points, we have the lowest one in the middle, actually following the contour of the hernia, more or less, and of the musculature, therefore. So if you do it at 3 different braces, the upper one a little bit more to the midline because you come closer to the ribs, then the middle one completely lateral because that's the biggest hernia diameter, and then the lowest one again a little bit to the midline because you have your shape like that. There are, as far as I know, no real benefits of using one technique or the other, and groups start and experience a certain protocol and are happy, or maybe some change, but I don't know about that in literature at least. So I think they are comparable. They might have pro and cons. Sometimes with the 5 point, the anatomical locations are a little bit more strict. If you do the 3 point, it's a little bit looking at the hernia gap, ultrasound, see where the muscles are, and try your 3 point evaluation with a good spread in the muscle if you are in the sheet. So I don't think there is much difference between the two.
Yeah, that was basically my question. If you have the hernia in a lateral position, or there's a lot of scarring, if you actually change your protocol accordingly, if you just
Yeah.
sort of watch where you've applied it. I have one more topic in mind. Something that unfortunately we can't completely ignore. It's the money, it's the cost of the procedure. So we know the bottle of Botox is a few €100. It's not the end of the day for majority of the patients, but there is the procedure itself. Um, are you aware of any calculations how that works against performing component separation? And then what is the cost of the complication connected to major hemorrhage or something connected to component separation that could have been avoided had you used Botox?
Yeah, I think the data is, of course, very different between countries, healthcare systems, financing of the system, and so on. Sorry. I think in general, it should be very clear that with the very small amount of money that Botox costs versus the management, longer hospital stay of a complication with component separation, I think maybe it comes out of different pockets in a certain healthcare system, and that's might make a difference in different countries. But if you really look at numbers of cost, I think Botox cost is very, very minimal compared to what you might prevent using component separation. So I think per se, as such, it's not really a discussion. It's a fact that Botox, if you can prevent in that way component separation and its possible complications, I think there is a no-brainer to use more Botox and less component separation.
We're coming close to the end of this session. Do you have any more questions, Barbara? I have a couple more questions, I think.
Why did that not surprise me?
One of them is a question actually stolen from Barbara we discussed before this session. I'm not aware of any, but are you aware of any literature looking at Botox for transverse incisions to relax rectus muscles to try and get the edges of the fascia closer together?
I'm aware of one study, but not worth mentioning because it was just a tryout and say, oh, we injected it in the
Wasn't your
rectus muscle.
study,
It
no?
wasn't my
No.
study. In general, if we look at what we want to achieve, we do not want the rectus muscle to relax. I mean, that is something actually we want to bring them to the midline, and it's not the muscle per se that will help us doing that. It's actually the relaxation, the what they call chemical relaxation of the flank that you need to bring your rectus muscle to the midline. So I don't think it's a very logical idea, not in midline, but also not in transverse. The mechanism of bringing your hernia gap smaller or making your hernia gap smaller comes from your flank and not from your rectus muscle. On top of that, I think even when you use, for example, in HPB surgery, like we do a lot, the hernias are mostly in the midline anyway. So the principle of bringing the midline together stays the same, whatever type of incision.
Last question. I promise it's the last question. It's kind of an extended indication of Botox. 1 minute response. Botox to help closure of the open abdomen?
Experimental phase, but might be promising. It's a 10-second answer. I think the problem with open abdomen is actually more the time you need to have it open or you don't need to have it open to solve the real problem and indication for the open abdomen on itself. But I think also there we might be able to prove that using Botox, we might prevent mesh traction a little bit. We might prevent some component separations to get the open abdomen closed. And so in total, that might certainly have some benefit, although if we aim for the closure of an open abdomen within 2 weeks, and we only start the Botox after a few days when we say, this will be a longer term, we might be late to have the effect of Botox. So it's still in an investigational setting, I would say.
Is there any rapid effect drug which would have similar effect to this, to Botox?
It gets really difficult now. Not that I know of, but I didn't think of that in terms of what could paralyze your muscle more quick. I think that is something for the future, maybe. I don't know.
Frederick, absolute pleasure to spend some time with you and with Barbara, obviously, too. I think there's been something for everyone. We're up to speed with the literature. We have a good idea for those that haven't started Botox, how to start a Botox program safely. It does involve using your friends for the most part, whether that's anaesthetist or radiologist, whoever is skilled in ultrasound. There's still a lot of unanswered questions. There's still this off-label use that hangs over many countries. But thank you very much, and look forward to meeting you again soon. Thank you.
I think we are live. Welcome everybody, and thank you for watching. Frederick, congratulations again. It was fantastic, and I have learned a lot. I was very happy I got to see it one more time because it was a very refreshing talk. And we have two more questions from the audience. One of them has already been answered, so 2 extra ones. And the first one is do you have any cutoff? When do you use Botox? Is there any diameter of the hernia? Is it some other patient-related characteristic? When we kind of didn't really discuss that.
Yes, thank you, Barbara, for the nice comment and of course for the question. So, of course, it's a combination of things, but considering aspects of patient and hernia characteristics, I think when we just look at size of the hernia gap, I think as soon as you think about maybe I need an extra tool, and that is in the literature around 7-8 centimeters, according to some really nice studies. Of course, as I mentioned, I think it was Andrew that asked whether obesity has a big influence. I think you should be careful in obese patients because when you start separating the layers in the abdominal wall, you can come across some surprises. And so better take the safe side in those patients and maybe go even to 6 centimeters for a defect to see whether you might need Botox infiltration, specifically because the complication rate is so low.
Related
How's
to that,
it in your practice, Andrew?
I guess it's a combination of what do you think the patient can achieve. So, you know, to a certain extent, in the obese patient, you may want to use it at a lower width, but at the same time, they have the potential to lose weight and perhaps buy you space. The real problems are people of BMI of 25 getting down to 20. They're not going to gain much space by losing weight, and you're going to have to do things to elongate the abdominal wall. Related to that, though, Frederick, was someone asked about your cutoff for pneumoperitoneum. I know it wasn't quite the topic here, but what goes through your mind? We've got some idea now that you're going to go straight to theatre after prehabilitation. We've got some idea of that you're going to add Botox. What's your indication to then go to the next step with PPP?
So my personal opinion, but I'm sure I know that some of other experts have different opinions on that. But my own experience and therefore opinion is that Botox is not enough, almost never, to solve a loss of domain issue. And loss of domain for us, we are a little bit in agreement with the literature. From 20-25% of loss of domain, we will perform a short term of pneumoperitoneum. What do I mean by short term? It's only like injection days, 4 or 5 days by 1 liter per day and an initial insufflation of 2 liters. So around 7-8 liters in the very small, rather small loss of domain patients. And the maximum that we do is 2 weeks of insufflation, which means 16 liters in those extreme cases. But loss of domain treating by only Botox, I think you might limit your options during surgery, and then it's relatively too late. So the same as for Botox, I take rather the safe side, knowing that the downsides of pneumoperitoneum and the complication rate is certainly something to consider, and not doing it, whenever you feel up to it. But take the safe side and use it when you think you might need it.
There was a question earlier about you've brought the patient into hospital, you've given them their Botox, probably in radiology or anesthetic room or a clinic. How long do you keep the patient around in the waiting room before you let them go home in case they have an allergic reaction?
We let them wait 30 minutes. And then if there is no specific feeling, in my mind, it's even more because you might have some hematoma, some extra pain, some problem from the injections, because those we do it without anesthesia or whatever, are quite painful. And you might, of course, hit some blood vessel in the muscle, and therefore we let them wait. I have personally, fortunately, no experience with allergic reactions so far. So I think it's rather rare because we treated in the meantime quite some patients, but we let them wait half an hour just to see in general if they are well.
Yeah, I'm not an expert on allergic reactions either, but I understand that repeated injections, we can form antigens to we form antibodies to the Botox antigen. Yeah. So I was planning to get some Botox to tidy up my face, but I'm worried I might need it in the future for my abdominal wall repair. So I will just have to carry on
wait a little bit,
aging gracefully and make sure I'm not allergic to Botox.
Great idea.
I have two comments, if I may. One is about obesity. We keep talking about obese patients, and I must say, when you compare them to the real malnourished patients, the super skinny patients, I love obese patients because they're so easy to treat compared to the ones who have nothing to lose and they have no abdominal wall. Do you have much experience with those, like severely malnourished that have retracted muscles, no skin over it, very, very thin layers?
Yeah, of course we have some experience. It's not tens of patients, but over the years, of course, you see these patients. The first question for me would be, is your hernia really the issue that will make you better? But I think you're right. I mean, those are maybe even more dangerous patients as an overall status than the obese patients. I think the general condition there determines the outcome more than maybe the hernia repair itself. Of course, I agree with you that you can have thin skin and no musculature. So what can you bring together? What does it result in? But I would more worry about, let's say, healing problems in those malnourished patients than that I really would about getting the abdominal wall together. I think that might be comparable, but the healing process might really be a tough one for those patients. So you're absolutely right.
Yeah, and patients with obesity can be malnourished too, particularly if they're protein malnourished or they're sarcopenic. It's amazing the variability of the abdominal wall on CT scans. And some can be very thready and a bit full of fat, and others can be incredibly thick muscles. So I think sarcopenia is something that we're looking at more and more too.
True.
But you at least have some skin, if nothing else, which on the malnourished ones, sometimes even that is very, very sparse. And one more comment, if I may. We are academics. Maybe we should stick to some academic talk. We speak about Botox, and some of us even say that our favorite Botox is Dysport. So it's a botulinum toxin, isn't it?
Absolutely.
Somebody wrote it to me in a message during the webinar. So I'm just passing the message that we should keep an eye on what we say. And thank you very much for the comment to those who are listening and correcting us, because it's a constructive criticism and we're very happy for that. Is there anything else you would like to add?
It has been a masterclass, really, and one of the participants commented on that too. And I've heard it before because we had to pre-record it. And listening to it again, I've learned even more. I guess I paid a bit more attention. So I would recommend people to watch it more than once. It's been a superb effort. Thanks again, Frederick, for all your hard work and putting it together. And my co-host, Barbara, the brains and inspiration behind Hernia Basecamp. So thank you all very much.
Thank you.
Can we say the secret? Is it allowed?
What secret?
What we're working on?
You can do.
So for those who do like to use this chemical component separation, to be correct, we are working on some articles and some papers, and hopefully next year we will have a very short and practical guideline how to start using it, what to do, and some guidance on how to do it. And we hope it will also help us bring it from the off-label state to a new indication for using these chemicals in abdominal wall reconstruction. So there's some light of hope for us for next year, and I'm very excited about that.
Yeah, the EHS Botox guidelines, they're under development. Yeah, that's cool.
Will be great.
Yeah. Well, good night to everyone. Thank you for taking part, and I wish you all the best Botoxing your patients.
Thank you all. Bye-bye.
Bye. Thank you.
WebSurge is proud to present an exciting new learning platform.
Once again,
are you finding it tough to track down reliable information for
Thanks
hernia surgery? Do you want to hear from world-leading experts in one simple, easy-to-navigate, unbiased and accredited place? Then welcome to Hernia Basecamp. Simple to navigate, you can watch videos, recorded webinars and conference lectures, all supported with suggested reading. It's a completely free of charge online resource for everyone with an interest in hernias. An educational program with 3 main aims, 8 chapters and the world's leading experts, with certification on completion. You can attend lectures, view videos or look up information, keeping you up to date with the latest views and technology via a user-friendly interactive platform. We're taking hernia care further together. So visit websurge.com and start your journey today.